Hi everyone, I am Francesca Cerutti, Gold Member of Style Italiano Endodontics. Today I would like to share with you a short lecture that I developed in collaboration with Fanta Dental. The lecture is about shaping because one of the things that are mandatory for us to improve our endodontic practice is to be in control of what we are doing during this phase of the root canal treatment. So I will share with you a short recording I did of this lecture, and then I will be available for answering to your questions if you have any. So enjoy. How to be in control of shaping. What do we want when we shape the root canal system? First of all, we want to respect the anatomy of the root canal. Then we want to be efficient in our shaping. We don't want to waste time while we are shaping the root canal system. And then we want to be predictable because we want our results to be repeatable and we want to provide a good standard of quality to our patients. And last but not least, we want our shaping to be safe. We want to avoid the risks that are related to root canal shaping, such as perforations or apical transportation or file breakage, etc. And so this is one of the cases that I manage every day. A large decay in a young patient, have to raise a flap and do a pre-endo build-up in order to be able to isolate. I did my shaping. I was as conservative as possible. I tried to respect the original shape of the root canal system. I failed. Then the patient had a post-endodontic restoration. But what I wanted it was that my preparation was centered into the root canal and as complete as possible because we know from the literature that it's impossible for our instruments to touch all the walls of the root canal system, but at the same time we want to be as good as possible in our shaping, and this is the result. So as you can see, there is a complete healing at the 2 years follow-up. And so we are satisfied with our result because we were able to decrease the amount of bacteria that were inside of that root canal system, and we were able to accomplish the healing of the case. But also, we want to be conservative nowadays. We want to respect as much as we can the pericervical dentine area because we know that this is what makes our tooth able to survive long term the occlusal loads that it has to bear every day. And 0.3 is the thickness of dentine that is considered critical from this point of view. So when we shape, we have to remember that we have to leave at least 0.3 millimeters of dentine around our preparation. That's why we are switching towards more conservative preparation. But one thing that nobody can tell us, and there is no article, no consensus in literature about this, is which apical size and which taper is better. Because nowadays, there is no significant difference in the outcomes of cases shaped up to 35, 40, 25. We really don't know. And about the taper is the same. And it's extremely depending on the original anatomy of the tooth, because obviously in a calcified canal, I cannot think I can go with the same sequence, same instrument that I'm using in a very young tooth with large root canals, etc. But in different scenarios, in different cases, we want to get the same result. In some cases, our taper will be greater. In other cases, the taper will be smaller. It depends on the anatomy of the tooth. And it's up to us to choose which sequence is better adapting to the anatomy of that precise tooth. And when we prepare, what are the guidelines for a practice of quality, according to the European Society of Endodontics, is that the prepared canal should include the original canal. We don't have to deviate from the original path of the canal. And then we should maintain the apical constriction, so the preparation should be tapered. We don't want it to be straight. And then the canal should end in an apical narrowing. That's the same thing that I was saying before. And why we want our preparation to be tapered? Because for us it will be easier to clean and to obturate a tooth that is prepared in this way. What about the problems that we can encounter while preparing a tooth, while shaping? We can encounter the breakage of a file. We can encounter a wrong path, because in the case you see on the left of the screen, there was a broken file, and then probably the person who did the root canal treatment tried to pass, but wasn't able to bypass the file, and so ended up in a straight path that was almost perforating the root. Or we can find an overfilling. An overfilling means that the incisor that you see in the second image has been over-prepared, over-shaped, and then overfilled. And then what we can find perforations when there is a complete misunderstanding of the anatomy of the pulp chamber floor, and so there is a wrong identification of the position of the root canal openings. And then we can find ledges. This is extremely frequent in retreatment. Many cases of retreatment are ended up as failures because a ledge did not make the clinician able to arrive to the apical third of the tooth, and so the preparation and the filling remained short from the original length of the root canal system. And then we can find a combination of all of the above, so a post, a ledge, short obturation, etc. And to face these problems, we have obviously two types of solutions that are quite different from one another. The first solution is to prevent these mistakes. The second solution is to solve an existing problem. And so we are going to focus on the prevention in this case. So we want to plan adequately our case, want to make a correct access cavity, negotiate the orifice, do a coronal pre-flaring that allows us having a easier access for our files to the middle and to the apical third. And then we want to do the scouting of the canal. We want to understand what is this canal like. And then we always have to remember to have the patency of the canal. And then another thing that we could do to prevent many mishaps in root canal shaping is to use the nickel titanium files one time only. And this is extremely important, above all with the files that do the greatest effort. So the first files that we use that are going to be more stressed than all the others should be used only once and then discarded. What about the planning of the case? One interesting thing that one could do is to assess the complexity of the case preoperatively. Above all, for young clinicians, it's important to understand whether they are able to treat the case because it's a middle to low difficulty case, or it's better to refer to a specialist, for example. The same is valid for a GP. Try to understand before working on the tooth if that tooth is something that you can manage. Otherwise, it's better to refer in order to avoid further problems. Second, the access, which is of paramount importance, because if I do the access wrong, then all my root canal therapy will be done in a way that is not correct. And so please try to do a correct access cavity, because many problems come from a wrong access cavity. In this case, you can see two lateral incisors where the access cavity was oriented to buccal, and so the colleague was not able to find the root canals, which were not easy to find, but with this kind of access, it was impossible for him to find them. Or another problem, wrong access cavity, wrong reference point for finding the MB2 perforation. And so even in this case, a correct access cavity would have helped the colleague to avoid this kind of mistake. Third, a perforation that was shaped and filled. Even in this case, a wrong access cavity didn't allow the colleague to find the opening of the mesial canals. And so the mistake, the perforation, and all that came later. Then he referred the case to me, and I was able to remove the gap aperture from the periodontium, repair the perforation, do the retreatment, and the tooth eventually healed. But what should we focus on while we are shaping the root canal system? Well, first of all, we have to understand the phases of shaping, because it's not that I take one file and I go straight to the apex. It's not happening. It happens in very few cases. So we should think about pre-flaring, glide path, working length, then shaping the coronal 2/3, and then the finishing, which means shaping the apical third. And what is the pre-flaring? Why do I do the pre-flaring? I do it to reduce the coronal interferences, and so my files will be less stressed, because if the file works for its entire length, it's easier for this file to accumulate a lot of stress and to separate. If the stress are less, there is less chance of breaking the file. So when I choose my files, I can go with manual hand files in stainless steel or rotary files, engine-driven in nickel titanium. And whether I choose to do manual or manual-less shaping, I still have to make a glide path. So there is a path that guides me from the opening of the root canal to the apex. And what does the literature say on this topic? It says that rotary files deviate less from the original path than stainless steel files, and they are associated with less post-operative pain than stainless steel files. And what are the characteristics of the files that I should use to do my glide path? They should be small in tip and small in taper. I have to use a thin file, very flexible, to arrive and do my glide path. And also, maybe a short pitch is better to be more in control of what you are doing, depending on your experience. And if I do a glide path, it will be easier for me to preserve the original anatomy, because all the files that I will use later are going to follow that path. And so there is less chance of deviation from the original path of the root canal. So I want to have this smooth path from the crown to the apex. And the benefits are obviously a better shaping, less risk of fracture of the files, the respect of the original anatomy of the tooth, and if I do it with rotary files, it's simple. What are the risks if I use manual files? Is that in many cases the tip of this file is active and they are stiff, so they are difficult to manage in some cases, avoiding curved canals. And so what can happen? I can create ledges or blocks, or I can just go all the way wrong and do a wrong path and a perforation of the root. And when I've achieved my glide path, what can I do? Then I have to record the working length. And there's an interesting article that compared the different ways that we have to record the working length, that are the tactile sensation, the periapical radiography with instruments into the root canal, and the apex locator. And not surprisingly, the most accurate system to record your working length is an apex locator. Why? Because above all, when there are particular aberrant anatomies with the superimposition of structures, it can be difficult for us from a radiograph to really understand what is the position of the file into the root canal. And so it might be difficult, the interpretation of these X-rays. In these cases, more than all the others, the use of an apex locator can make our life easier and can be extremely more precise than the interpretation of an intraoral radiography. And so, what are the advantages of using an apex locator? The advantages are many because I can check and recheck several times the working length of my files because above all in curve canals, after the shaping, I have a reduction in the working length because maybe the curve is going to be straightened up a little bit, and so the length of my root canal will be shorter at the end of the preparation. So I can check many times without exposing my patient to x-rays, for example. Another thing is that the accuracy is greater with apex locators than with any other kind of measurement, tactile sensation or intraoral radiography. And one could argue and tell me, okay, but there are different generations of apex locators, different type of apex locators. And so the real difference is the conditions in which these apex locators work and the way in which they measure the length of the root canals. Because generation by generation, there were some improvements in apex locators. And the most recent one are measuring the thickness of dentine around the root canal. And so when they arrive at the foramen, they tell you, okay, there's no more dentine around, you are the foramen. Some others measure the impedance of the root canal system. So there are different ways. But what, as clinicians, we are interested in is that the latest generations of apex locators are extremely reliable. They are extremely precise and that they can work even in conditions that are a bit extreme, maybe with some moisture inside of the root canal. And so they help us more, above all in those cases in which we really need to know what is the working length. And so Fanta Dental developed an amazing apex locator that they call 𝗰cie. And 𝗰cie has several advantages. First of all, the fact that it is very lightweight and I can carry it around with me with no problems. It's small. And since it's using a multi-frequency technology, it can work nicely in wet and dry canals. I don't have to worry about the conditions of the inside of my root canal because it's going to work anyway. And so this is extremely nice from my point of view. And then what it has, as you can see, I'm setting up the reference position of the apex locator. That means that it is going to tell me, okay, you're at the apex where I decide. And so this is extremely nice. It's auto-calibrating, so I don't have to do anything. It's ready to use. And also, it has a high resolution screen that helps me because it's a big screen to see immediately where I am. Also, with the sound, it helps me, but since I don't like too much to keep the sound on, I can just decrease the sound and watch at my apex locator. And it has a nice stand that you can adjust according to your preference. You put it wherever you want and you just put your apex locator on and you are all set and ready to go. So when I shape, I have to remember that I have to divide the tooth into areas coronal, middle, and apical third. And so I will start with my coronal pre-flaring, then I do my glide path up to the working length. And in this case, I'm using the Italiano endodontic selection of the Fanta F1 kit. So I'm using the 1303, followed by a 2506. Why? Because I skipped one, because the anatomy of the root canal allowed me to do that. Because if I put the 1303 inside and it comes out completely clean, it means that my canal is way larger. And so I can just skip to the 2506. With two instruments, I could be done. So I check the working length, and then I'm ready to shape up to the end of the root canal system. And so in this phase, I choose which is the last instrument I'm gonna use. I'm going to choose the final size of my apical preparation. And if I see that the 2506 has not worked on a step, it means my apex is larger than that. And so I can switch to a larger file in the tip, but with a smaller taper because I want to be conservative. And so I can use a 3504. And so in this way, I keep my preparation as minimally invasive as possible while being sure that I shaped also the apical third up to the ideal size, because I want to keep my foramen as small as practical according to Schilder's principles. And so I don't want to over enlarge my foramen. I don't need that. I just need it to shape what is required for my therapy to succeed. And then what I do? Final rinse, fill in, and post-endodontic restoration. And I'm done. How can an endomotor help us in this situation? It can help us by making our life easier in some ways. First of all, from my point of view, since I'm doing a lot of endo and I have the endomotor in my hands all day, the lightweight and a well-balanced motor can help me a lot. And then what else can help me? The fact that a motor can be adapting to my working condition. If I can rotate the head of the contra-angle and fix it in different positions, it's easier for me to find the most ergonomic position to work in. And so I can always see the screen, for example, and it's easier for me to shape. Then the fact of having programs. I have 10 memory settings, so I have all of the programs that I need. And if I am a GP, I have already set most of the programs that associate with the rotary files that we are going to use. If I'm a specialist and I want to change the rotation per minute, the torque, and whatever, I can do that easily. And another nice thing for me is that the motor is wireless. I hate to have wires all around when I'm working. So as many wireless things that I have, the more I'm happy. And also the fact that I can set everything in this motor, because I can choose clockwise, counterclockwise, reciprocation motion. I can control the torque. I can decide whether the apex locator that is built in this endomotor, when I arrive at the apex, makes my file go in counterclockwise motion. Or I can tell the motor, no, I want apex locator and motor to work separately. So I want you to tell me when I'm shaping at the apex, but I don't want my file to stop working. I want to be in control of what I'm doing. And so the possibility to choose and to have always in control the torque of the instrument, etc., is for me extremely important, because I can check in every moment of the therapy what I'm doing and what are my files doing. In this case, I can avoid several errors. And so, what about the files? I can have plenty of files to choose, and most of them easily adapt to the iRoot Pro. So there is a huge variety of systems that you can use with this motor. And what is the influence of an endomotor on the behavior of root canal files? Because maybe some are performing better than the others, etc. And what the literature says is that most of the endomotors obtain good results in terms of reproducibility during the continuous rotation movements. When it comes to reciprocation, some are performing better than others, but anyway, the endomotor can influence, obviously, the mechanical behavior of endodontic instruments, because if the rotation is not correct, if the torque setting is not correct, I'm not in control of what I'm doing. So choosing a good quality endomotor can make your endodontic life much, much easier. And what happens when I combine an endomotor with an apex locator? Well, I can avoid these mistakes that I'm showing you. So I can avoid the overshaping of the root canal system, because if I set my working length in the wrong way because my rubber stop moved, so I recorded 22 while my canal is 20, it means that every file that I'm using is going to shape 2 millimeters more. And this cannot be such a huge problem with small files. But when I'm using larger files, I can do an apical transportation. I can over enlarge the apex. It's not correct. And so having an endomotor that constantly tells me you are in the wrong position or you are in the right position, for me, is helpful a lot. So I hope I was able to clarify a little bit the problems that we have while shaping and how to prevent these problems and how technology can help us in achieving good results. And this is it. If you have any question, I would be more than happy to answer. So thank you very much for watching. And I don't really see questions. I only see a comment from Federico Foschi, which says, if you tell us which size to shape, it's expert opinion. Yes, it is, but I think there's nothing better than just watching the spires of your endodontic file and see where they work. Because you have to remember that until you don't see white dentine on the spires, it means that you still have to shape. And so it's very important for you to analyze your endodontic files right after taking them outside from the root canal. That's, I think, the best way to know to which size you have to shape. So I don't know if there are other questions. Okay. So thank you very much for watching. And if you have other questions, you can just write them in the comments and I will get back to you. Bye. Thank you.